warm welcome to the PHEMS meetup. So this is the third session of our winter meetup series. My name is Pekka Kahri, working in Helsinki University Hospital, and will be hosting and presenting today with the topic of the pediatric health data space, sharing data in the context of the European Health Data Space, or EHDS. So our winter meetup series is now on the third session with all the previous ones, and also our meetups from last autumn. They are available on our YouTube channel, and you can revisit them there, or you can subscribe to our channel so you see all the meetups recorded there. As usual, so there will be first a presentation of about 25-30 minutes on topic, and then we will activate mics and cameras for all the attendees, and there will be an interactive session. The presentation part will be recorded, but then the interactive part will not be recorded and shared, so it will be an informal part of this meeting. As always, so a brief update on what is PHEMS all about. So we are a consortium of 14 partners funded in the Horizon Europe program and by the UKRI, and we are working towards creating a pediatric health data space. Involved are 6 pediatric hospitals from across Europe, whose Helsinki University Hospital being the coordinator. Other hospital partners are Great Ormond Street Hospital for Children in London, Sant Joan de Déu Children's Hospital in Barcelona, Erasmus Medical Center, Sofia Children's Hospital in Rotterdam, Mayer Children's Hospital in Florence, and the Latvian Clinical University Hospital for Children in Riga. In addition, there are technical and business partners which help us in building the technical infrastructure, harmonizing the data, and also creating the sustainability and business model for our project. We are a 3-year initiative which started in October 2023. We are exactly halfway of our activities, so we are coming to month 18. Midterm reporting, total funding of 7 million euros, funded jointly by the Horizon Europe program and UK Research and Innovation Agency. Today's topic is about data spaces. So when we talk about pediatric health data space, so what does that mean in the context of EHDS? And I would like to start by briefly referring to some definitions of data spaces. What are they, and what are the definitions that are being used? So here are just a few, but they all have common that stating data spaces as setups where there is common data infrastructure, there is a common governance framework, and somehow it helps in collaboration over data. So the wordings are slightly different depending on where you look at, but they all are somehow encapsulating these three topics. It's around data and possibilities to share and access data, include technical infrastructures, and then about the framework for governance. And when we are talking about data spaces, so I'm building this presentation on the very recent seminars or webinars given by the European Commission on the European health data space, and comparing those topics onto what we have been working with in PHEMS. As you may have noticed that the European health data space regulation now was published, and it will become official by the end of March, where then starts the implementation period with certain timelines which make the regulation binding for different parties and all member states. So if we start by first thinking that what is purpose of a data space, why to set up a data space? What the EHDS is about, and these are slides that are directly used from the Commission presentations. So the European Health Data Space regulation combines 3 things. It tries to support the primary use of healthcare data by improving patients' access to their health data, and also ensuring seamless exchange cross borders for the continuity of healthcare. It includes secondary use, so the use of data for research and public interest purposes, and then it sets requirements for electronic health record systems. And what our interest in our project is mainly on point 2, so the secondary use of data, so data for research and public interest purposes. What is important in the commissions and the regulation is that EHDS is not an exclusive setup, meaning that if there are other reporting obligations, for example, for pharma, say they do not affect these obligations. If there is a other union or member state legislation that gives legal basis for processing of patient data, it does not affect these regulations. If there are existing frameworks for secondary use, such as research infrastructures or other that are based on agreements, they can continue to exist in parallel to EHDS. And there is an important scoping that these cannot be used for any law enforcement purposes. So this is an important point to add that EHDS will not be a monopoly, so it's not the only framework, only data space in health in Europe where things can happen, but it's clearly, of course, it's very, very important and a massive initiative affecting the European landscape. Then why did we start building the pediatric health data space, or why did we initiate FEMS project? So there the reason comes really from needs of pediatrics and pediatric healthcare. So as we know that complex pediatric patients or rare diseases are low in numbers. So in order to do scientific research that has some statistical power, so we somehow need to be able to collaborate cross-border and therefore increase the numbers of patients that are available for analysis. When we are getting new therapies to the market available for our patients, there is often very limited data available about their real-world effectiveness. And this is where collaboration again across borders becomes important for health technology assessment purposes or for providing real-world evidence for a medication that, for example, have a conditional approval for market introduction. If we want to engage with innovators and medtech developers, especially in the field of artificial intelligence, which is hungry for data, we need to be able to tap into several data sources. And this is the only way to get reliable and usable artificial intelligence solutions that can be deployed in healthcare cross borders. And then even for typical hospital improvement, clinical outcomes and quality improvement through benchmarking, many countries only have 1 or 2 children's hospitals that do the most demanding tertiary care. And therefore, the potential of benchmarking is not possible unless there is a way to collaborate cross-border. So the differences between where the EHDS stems and where the pediatric activity that we are doing in FEMS stems from are slightly different, but they are all going towards the same goal. How do we work together on data cross-border? Okay, then if going a little bit into the approach, how the data spaces are built, what are the principles of data sharing? So first of all, just doing very, very simple and very basic like dichotomy of 2 cases. So how to do analytics on patient level data. So if there is the opportunity that data users can get record level data for their processing in a secure workspace, so then the data users can themselves access, curate, process and analyze the record level data by themselves. But of course, as we are talking about sensitive patient information, so this can become problematic. The hospitals or other data holders might not be comfortable of sharing record level data to external data users, or if they share the data for the external data users, the sharing is done only in a highly controlled secure workspaces or secure processing environments, which often include then auditing and certification by authorities before they are taken into use. All the requirements from General Data Protection Regulation apply for these data, so there needs to be a legal basis for processing, and there also has to be a legal basis for transferring the data to a data user. The advantage of this, or the other side of the coin for the data users perspective, of course, is that there is a direct access to the dataset. They can view and utilize individual level data, curate it, perform analytics with it, all the tools that are available in the secure workspace that they have. The second part of or alternative for data analytics is what we call federated data analytics, where the idea is that data users, instead of getting access to the record level data, they are granted permission to send analytical code to a database and then receive aggregate results of this analysis when executed. So for this, there are also GDPR requirements. So there has to be a legal basis for this processing. But since there is no transfer of sensitive patient information, this is much more easily accepted and much less legal troubles ahead with this way of working. Also, the secure workspaces where the data users are using, the requirements are a bit more relaxed because there is no sensitive patient data transferred there, only aggregated results. And this means that the data controllers never release, in fact, any sensitive patient information from their internal systems. The downside of this is that then data users never have direct access to the dataset. They can't view sensitive individual level data. They can't perform detailed analysis by querying themselves directly to the data. So these are the two basic models. And now if looking at how the data spaces are built, so European health data space is built on a user journey which is aiming to get the data collected in one space and made available for the data user. So it starts with the discovery, what kind of data exists to support the research. There is a data access application, which is done to a relevant authority. Can this data be shared for my project? Then there is data preparation and data provisions, where the data holders make the data available into a secure processing environment where the data users will have access to. And then there is the analysis and processing of the data by the data users. And the results are then published, of course, first ensuring that there is no confidential information leaking out of when the results are being published. So the user journey in the European health data space, the EHDS, is built on pooling data together and giving access in a secure processing environment for data users to use the data. There are also architecture pictures about the EHDS setup, which the abbreviation HDAB means the Health Data Access Bodies, which will be authorities in each member state having quite many activities and quite extensive infrastructure in their possession, coming from public metadata catalog, data access application handling, and then the secure processing environment where the data is collected from data holders and made available for data users to process. Then looking at what is our approach in the FEMS project, so the federated approach here is selected. And this is a very crowded slide, but I'm trying to walk you through it a bit. So in fact, the process of data usage, stages 1, 2, 3, and 4 are quite similar or quite alike of that in the previous slide. So first, finding out what data is available, then making an application for a data permit or data access. But then when the processing comes, so the data processing is done federated, meaning that the sensitive patient data is not leaving the data controller's environment. And then before the results are released, there is a check that no sensitive personal information is leaking out. And the architecture of the pediatric health data space that we are building in FEMS project includes workspaces, which are places where the data users work, and there can be several different types of workspaces. We'll just put there examples of 3 different types of workspaces. That could be one for clinical benchmarking. It could have the required dashboard functionalities to do clinical benchmarking between hospitals. There could be an AI development user group that wants a federated machine learning workspace, which helps in model building and then federated learning of the machine learning models. And then there can be research teams that are doing scientific federated analytics on a project workspace. And they all link to shared services, which are relatively lightweight, consisting of a data catalog and a shared Git repository, and then linking into individual data sources through a technology we call the federated nodes, which are the technical components that link a harmonized OMOP database in each data controller into this data space, and allowing standardized analytics to be run over several data controllers. And then the aggregated results are collected together, controlled, and then returned to the data users workspace. So this is the approach that we are building in FEMS project, where the basis is on, as said, on federated data analytics, on harmonized databases, and it on top of the OMOP common data model, and some shared services which are significantly lighter than those that are required by the health data access bodies in EHDS, consisting of a shared catalog and a Git repository. So what are the main differences of these approaches and the consequences? So clearly there is much more centralized components required in EHDS. The health data access bodies will be central authorities that have a lot of role in the data discovery, data permit, and they are also providing the infrastructure for the secure data processing. Whereas FEMS is building on a more decentralized model where the data is always hosted by the data controllers, so hospitals, and then data users can access it via federated analytics. When there is a data pooling of sensitive data, so there is a need for a secure processing environment, or an SPE, which has to be audited and certified. These are already in place in some countries where there is national legislation anticipating the EHDS, but many countries will have to build these secure processing environments and have them audited and certified. Whereas in the federated analytics, there is pooling only of aggregated results in a secure workspace, so those workspaces are much more relaxed in their requirements. We see that the centralized or shared services differ in their extent quite significantly, and also the requirements for the secure workspaces are quite different. There is also a fundamental difference in what kind of analytical methods can be performed and how the quality of the data and the results, so the resulting evidence, is demonstrated. So a federated analytics is building on harmonized databases, and it requires that the data quality is somehow verified in the data source, and also that the analytics that is being used is verified and is providing reliable evidence. When it comes to pooling data together, then there is more control over the data quality inspection by the data users themselves, but in similarly, they also have to provide sufficient methodological quality and evidence, so that the evidence is reliable. All right, then a few words about timelines. When can we expect value from data sharing? So if we're looking at the European health data space, so this is a massive European initiative where now the regulation has been published. It becomes formally endorsed and in power on the 26th of March, so in less than 2 weeks, or about 2 weeks. And then starts the transition period, which continues well over to the 30s, with the first milestones or deadlines being in the March 27, meaning 2 years after the entry into force, when there has to be, for example, health data access bodies designated in each country. The lowest track here, the secondary use, is the one that we are mostly looking at. When does the value from working on analytical studies based on European health data space will start? And here it shows that around March 2029, there will be first usage of data based on this data space. So data users can start applying for permits and requests on March 29. The health data access bodies have to be designated latest on March 27, so in 2 years, and then they have 2 years time to set up their activities so that they start receiving data access applications on the March 29, and at the same time there has to be also secure processing environments in place. If we're looking at our project FEMS, which is of course much more modest in its scale, but we feel that the impact may come a lot sooner. We are an EU-funded project ending in the end of September in 2026, and we have now started, as part of our project activities, the preparation of how the infrastructure and the governance framework that is developed in the project is established into a permanent structure, what we call the Pediatric Health Data Space, or PHDS, so that when the project ends and our grant is used, so we would have the PHDS established. It would have an economical model which would help it to sustain its operations, and we would have the necessary activities up and running for the data value to be created. Then just a few words about preparation. How can hospitals prepare for being part of data spaces? So when looking at European health data space, so all data holders, including hospitals, they will be obliged to make their data available. The first deadline is to provide dataset descriptions, so that health data access bodies can create their centralized catalog. And then they have to be ready to provide data if there is a data access request or a data access permit. And this comes into effect in March 2029. Then if looking at what kind of requirements are there on the dataset catalogs, so data holders will have to provide basic descriptions of their datasets, and there are standards and requirements that are being defined how these descriptions have to be submitted. There is also another activity which is building a data quality and utility label, which would make visible what is the quality of the data source, what is the maturity of the data holder in terms of its processes and data governance, and also what is the utility of the data, meaning to what purposes is this data used, and what are the experiences of using it. So these will be developed with the European health data space, and they will become binding for data holders. If we look at our activity in PHEMS and the pediatric health data space, So we are following very closely what is and has been the development of the EHDS regulation, and we aim for maximal alignment, meaning that when we are talking about data discovery, we would lean on the metadata standards and data catalog definitions that will be mandatory through the EHDS. We would also align our data permit processes, especially in terms of templates, what kind of content is required for making a data permit or data access application, and we can align with that. And then when applicable, we can also look at what kind of requirements and specifications there are for the secure processing environment, bearing in mind, however, that our approach is on federated data analytics, meaning that data holders would not release sensitive patient information, but only aggregated results. In any case, there is a need for secure workspaces. We need to be able to strongly authenticate who are the data users. We would have to link a workspace into the data permit so that the processing requests and the return of the results is managed without any possibilities of confusion. And also we have to make the IPR considerations so that the data users, the potential IPR that they are generating can be protected by these workspaces. But in terms of data privacy and data protection, maybe the requirements for these workspaces are more relaxed when compared to when pooling sensitive patient level data together. Our vision is that by becoming a participant in the pediatric health data space, so data holders can invest in building capabilities that directly meet the requirements coming from the EHDS, meaning that if a hospital wants to start working with data collaboration based on our approach already prior to EHDS becoming fully in force and applied, so the investment made here will not be somehow separate from that, but it builds on the same capabilities. If looking at our timeline a bit more on the potential roles that our pediatric health data space is providing, so our idea is to make this an scaling ecosystem or data space with several types of participants being able to join. We are aiming to start with the hospital partners that are forming the core of the consortium. These 4 hospitals, Helsinki, Gauche in London, Erasmus in Rotterdam, and Sant Joan de Déu in Barcelona, would establish and constitute the data space together with ECHO Association, who is a collaborative organization for pediatric hospitals in Europe. Any other member hospital in the ECHO Association can join as full participant. Other organizations that are not members of ECHO Association, they can join as associated participants, meaning that they can provide data, they can have participation in benchmarking activities, and so on. And then the ECHO Association takes the role of the governance entity and hosts the shared services that are needed for this data space. Then we have data technical partners that can be as workspace providers or other service providers in this context. This concludes my presentation. I still once more come to the important notion on the European Health Data Space Regulation. We are often being asked, and we are also ourselves asking the question that, is there a risk that when EHDS becomes in force, there will no longer be legal mandate for these types of collaboratives to work? And I think that this is a super important slide from the European Commission in that context, stating that this is European health data space is not an exclusive way to collaborate on data. There can be national or union law which gives legal basis for data processing. And for example, for hospitals, this is quite clear. For hospitals, when they're doing quality improvement or process improvement or research, clinical research, so there is legal basis for processing data, and then we can also set up activities with our partners. And then when there are frameworks for secondary use that are based on contracts, agreements, projects, so they can continue to exist. So this gives us a good view to the future that the work we are doing now is not being compromised or somehow made impossible by the introduction of European health data space. And I think that the two initiatives, maybe our type of federated approach will make possible data collaboration a bit sooner. Of course, when EHDS is fully implemented, it will have a huge impact on all research, especially when you want to do a record level analysis by pulling large data sets together in one secure processing environment. With this, I conclude the presentation. Thank you.